Good afternoon, everyone. Welcome to the Global Social Prescribing Summit. We're on to our fifth session. Clinical integration of social prescribing, practical guidance for embedding social prescribing in clinical settings. And from our last panel discussion, I think clinical integration of social prescribing is going to be crucial to the adoption of social prescribing around the world. Let me just start with a quick round robin of introductions. Let's go to London and bring in Dr. Silva. Over to you. Just a short round of introductions, please.
Hi, everyone. I'm Dr. Silva. I am a GP general practitioner in East London, in Bromley by Bow, where social prescribing was pioneered in this part of London.
Brilliant. Patricia, across the water to the US.
Hi, good morning. I'm Dr. Patricia Saleeby. I am a proud social worker and department chair of sociology, criminology, and social work at Bradley University here in the United States.
Fantastic. And Melissa? Oh, you're on mute.
Sorry about that. Hi, Dr. Melissa Sundermann, double board certified in both internal medicine and lifestyle medicine, coming to you from Ann Arbor, Michigan.
Fantastic. And Jill, I think you're in Europe.
Hi, good afternoon. I'm Jill Litt, and I'm a senior researcher at the Barcelona Institute of Global Health, but I am calling in from Colorado.
Oh, fabulous. Sam, who's in the UK. You're on mute. Go ahead.
Everyone, don't know if you can.
You're still on mute. Let's go to Professor Maheswar, who go ahead in India.
Okay. Hi, everyone. I'm Professor Maheswar Satpathy, and I'm a professor of global health, and I'm also the CEO and founder of Global Consortium of Global Health Actors, Leaders, and Thinkers, the world's largest global consortium of global health, and also the founder of Global Health Forum. I'm also the director of Center of Excellence in Environment, Climate Change, and Public Health and Policy in India. And I'm very much looking forward to today's conference. Thank you.
Thanks. Sam, see if we can get you back.
Hi, everyone. I'm Sam Pywell. I lead the social prescribing units here at the University of Lancashire in England. I work on research, teaching, and knowledge exchange projects at local, national, and international level.
Fabulous. So look, we're going to really focus on what does good and effective clinical integration look like. And I think we've got no one better than Dr. Silva from Bromley by Bow in London to sort of outline and sort of start the momentum. Over to you, Dr. Silva.
Thank you. So just talking about this, what does clinical integration of social prescribing look like? So I'm a medical doctor, and I like to think what I do is very important, but we all know probably about 20% of patient outcomes are related to direct medical care. A lot of it is around the socioeconomic factors. So integrating social prescribing within a clinical team is absolutely crucial. So it shouldn't be an add-on. It should be business as usual. A social prescribing link worker in all of our GP surgeries in Tower Hamlets, they're part of the clinical team. So they're just as integral to the team as I am. And we've got to make the referral process easier, which is self-referral. Receptionists can refer. Someone looks a bit off at the reception when they're booking an appointment with a doctor, you tell them, have you thought about a social prescribing and enabling direct access to the link workers who are based in the surgeries? And other important thing is timely access. So there are lots of aspects to this, but I think my kind of basic message is it shouldn't be an add-on. It should be an integral part of a clinical team, whether that's in the hospitals, whether that's in community health centers. It should be business as usual.
Thanks, but just could you elaborate a little bit, just to give context here, because it's come up a few times. Just explain to those viewers who are, because bear in mind the vast majority of people who are tuning in here from lower middle income countries and around the world, they don't really understand what social prescribing is, and maybe you could set the scene. And then there's a lot of viewers who will be tuning in here,
absolutely,
from various communities. Just maybe give us some context. Thanks.
So we know about 40 to 50% of life outcomes are because of what we call social determinants, which is your air, your water quality, where you live, your employment status, family support, social support, and so on. Medical care is about 20%. So we recognized it very early on, about 40 years ago in Bromley Bible, and then set up social prescribing as a way of not medicalizing everything. So rather than giving antidepressants to someone who's sad, you find out what, what the causes behind the causes. There's always a reason why someone's depressed. And why is someone getting diabetes in East London in their 30s and 40s? What's going on with them? So it's addressing the causes behind the causes. That's what social prescribing is, if you want me to describe it in a nutshell. And what happens is, so we've developed about 9,000 out of 9,000 patients out of the 50,000 patients we have in our GP surgeries have long-term conditions, whether that's diabetes, blood pressure, asthma, COPD, and so on. We've now integrated social prescribing questionnaires as part of long-term conditions management. So what happens is, when a doctor or a nurse or a healthcare assistant sees the patient, they ask them about, tell me about your housing, tell me about your income, are you stressed? And if we recognize this early on, and this has led to 15% increase in social prescribing. We've managed to unlock millions in income support for patients, managed to secure better housing, and now it's been embraced across Northeast London as part of all long-term conditions management. And one of the ways we managed to do that is actually to have the social prescribing link workers located in the health centers. So you don't actually send the patient somewhere else. You make them feel welcome because they're used to coming to health centers. It also needs a bit of a mindset change within the patient to say, yes, I'm a doctor, you come to see me for medicines, but that's not really what's going on, is it? So let's get you working with one of my colleagues. So it's been a journey of 4 decades, but I think we're there.
Yeah, I think so. I mean, it's just, and it's actually, its time is ripe now in terms of its adoption on a global level. So Patricia, I think it's so important to integrate, the practices, like how do we actually train and support clinicians to adopt social prescribing confidently and effectively?
Well, I think, like as Dr. Silva says, the first thing is to integrate it right there into the system. And I think once we do that, we start to raise awareness. And I think the experience will lend itself to an understanding of what social prescription really is and the value of link workers working cooperatively and collaboratively with our clinical health professionals. And we're going to, it's really place-based approach, right? We're there, we're meeting people where they're coming into those, primary care, offices or the hospital or whatever the clinical setting might be. And we're able to, I start to identify what are those non-health, more social needs from the very beginning. Because we often find we'll have someone, for example, I had a social worker who mentioned there was someone admitted into the hospital. And of course, first thing they do, the intake, they do the vitals, they did the basic screening, the diagnostic test to find that there was nothing, quote unquote, medically wrong, to determine what was the gastrointestinal upset that led them to come to the hospital. Well, that's all billable, and several $1,000s US dollars later, they referred that person out to the social work department. The social worker comes in and realizes the person is dealing with hunger issues. And as a result of the hunger issues and food insecurity, the symptoms that were manifested and presenting led them to come to the hospital, the pain and the gastrointestinal distress. If they would have had a link worker, a social worker there who may have been able to, who was trained, be able to identify the signs and symptoms, they might have been able to avoid the timely and the costly aspects related to that intake process. So I think it's really crucial that we see this as a continuum, as a team between health and social care. We need training. When we need formalized training, we need to work with the current clinical providers to help get this off the ground, while we're also simultaneously training the up and coming professionals through medical education programs, allied health programs, and so forth. So we need to be doing this both simultaneously through formalized education in our respective countries, as well as continuing education in our respective countries as well. Thanks
a million. And I think you make such a crucial point. It's part of the reason. I mean, we we have a partnership for this summit and this event with UCLAN. But we're looking at the wider aspect in terms of the opportunity around training and development. We published a roadmap during the week to be able to support that transition. And we're talking to a number of universities. I had a call last week with the University of Maryland, for example, to look at how we could adopt this program across the US. And there's significant opportunities there and across in the Middle East as well. But let me bring in Professor Satpathy. From your perspective, I mean, and you probably have a very unique insight here, given the work that you've done across India. Like, what are the barriers within primary care and hospital systems? Because you have huge, enormous hospital systems. How do we integrate social prescribing? How can we address them? I'm sure you've got a lot of insights here.
Yeah. Okay. So thanks, Gareth. While social prescribing has gained quite a lot of traction in high-income countries like UK, but its integration into LMIC health systems remains limited due to constellation of systemic, infrastructural, cultural, and resource-related barriers. So I think the health system is quite big, but the challenges themselves are also quite big if it comes to India or any LMIC. I am representing LMICs here because I think I'm the only person here who is from LMIC and originally based in LMIC as well. And I also represent the Global Consortium of Global Health, which is the world's largest constellation of Global South leaders, actors, leaders, and thinkers. So I think the question that you had asked is, what are the barriers? I think I would like to focus on few barriers here. First is the inadequate awareness and conceptual understanding. Many primary care providers in LMICs are not trained in principles of utility of social prescribing, and medicinal education often lacks inclusion of social models of care. There is confusion between social prescribing and basic referral mechanisms. And obviously, as you said, the health systems are big, but they are also overburdened. The health workforce is extremely overburdened because if you go to any government hospital, private public hospital, you would see every doctor at least sees 100 to 200 patients per day. And that's quite a big toll if you look at and compare to the national health system in the UK. Because NHS workforce, although they claim they are dealing with a lot of patients, actually they are extremely not overburdened. They're actually less burdened if you compare to India. So LMIC primary care systems are extremely severely understaffed, and the reason is not because we lack people. It's because the governments are unable to afford, and the health budgets are extremely low. And in addition, time constraints and burnout limit capacity for holistic person-centered consultations as well. Because if a doctor, just think about it, if a doctor is looking at 200 patients per day, do you think they can actually give the quality healthcare support that they actually need to provide? And emphasis also remains heavily on biomedical curative interventions over the preventive or community-based approaches. This is one of the biggest limitations of our health systems, especially if I look at Indian health systems. We have a long way to go before we actually integrate the healthcare system and the community-based approaches. And also, there is very little institutional or support or policy framework that exists to support innovative health practices like social prescribing. Absence of formal policy mandates or government-endorsed protocols for social prescribing actually makes it very difficult. And there is also weak institutional accountability mechanism to support cross-sectoral linkages. There is also fragmentation between health and social care sectors, poor coordination between healthcare systems and community or social welfare services, lack of interoperability between data systems, communication platforms, and reporting protocols. Just before this session, the other speakers were talking about it. Interoperability, I think this is very, very important right now as we are talking about AI and its integration digital health into the overall health systems in LMICs as well as all over the world. And there is also very little collaboration with the civil society and community-based organizations, CBOs. There is also limited availability of community assets, like in many LMICs. Community services such as mental health support groups, job coaching, or social clubs are scarce or non-existent. So where such services exist also, they are also very informal, unregulated, and underfunded. Government has very little role to play in that. And socio-cultural and stigma-related barriers also exist, and they cause a lot of problems. Deep-rooted social stigmas around mental health, domestic violence, unemployment, etc. They also hinder the uptake of social prescribing and other innovative health practices. Resistance also comes from both patients and providers. is not due to prevailing trust in biomedical only intervention. Many people just like to go to a medical doctor and get some medicines prescribed anyhow. And if the doctor doesn't prescribe them medicine, they in fact complain about that. And financial and logistical constraints also exist, and they actually complicate the entire process. Lack of dedicated funding streams for non-medical health interventions and poor infrastructure like transport, digital platforms to support access to community-based services, and insufficient mechanisms to monitor and reimburse social prescribing interventions also make it more difficult. And last but not the least, weak monitoring and evaluation frameworks. Like there is clearly lack of or absence of robust indicators, data systems, or research studies to assess outcomes of social prescribing. And there is also lack of cost effectiveness analysis and impact assessment in LMS content. So all these, if I have to sum up, all these barriers are very systemic and structural in nature, and there is very little effort by any entity, be it government or non-governmental, to actually make the social prescribing a reality in the context of LMS. So that's all from my side. Thank you.
Well, really appreciate the overview, and I think that's partly the reason why we started this discussion a couple of months ago, and I'm absolutely delighted you could join us here, because we have a huge challenge on our hands. But I think collectively here, if you look at the intellectual capital that we have on the panel here, and you'll have seen the panelists earlier, we can certainly help you, Professor Satpathy, and I know myself and yourself are due a call in a couple of weeks to sort of look at how we can bring some solutions and some financial support as well through some of the investors that we're talking to. So, thanks for setting the scene. And I think you kind of paint the picture that gives us all on this sort of panel the understanding that we have to do it together because it's such a big job. A big part of that will be the training and bringing in allied healthcare professionals. Sam, over to yourself. How can allied health professionals and the community-based practitioners play a more central role in delivering social prescribing and address the sort of inadequacies that have just been outlined?
Thanks very much, Gareth. Yeah, I just wanted to speak based on being an occupational therapist. I've actually been an allied health professional for the past 20 years. I've got experience teaching within curriculums, and I lead a master's module in social prescribing at the moment, which is an international module. And I'm a student myself, so I'm actually a third-year PhD student with the University of South Wales on social prescribing, looking at inclusive and effective teaching and learning of nature-based social prescribing. And critically, allied health professionals must understand their role in social prescribing. They must understand what other colleagues are capable of in the community for people's health, well-being. So we're talking about community leaders, community connectors, your social prescribing link workers, whether they're called transformational coaches. It doesn't matter what that individual's role description is, but the allied health professional really needs to lift their gaze and really understand the full spectrum of what it means to deploy social prescribing as an approach within integrated and non-integrated systems. We know the role should include referring to our social prescribing link worker colleagues, but that doesn't always happen. And when it doesn't happen, that can be due to a lack of understanding of roles. We know that allied health professionals should receive referrals from our community connectors, our link workers. And again, where that doesn't happen can be the direct result of the infrastructure not being in place due to lack of understandings, due to definitions, basic terminology. When you look at the interpretations of social prescribing and how it can be interpreted, the way that we teach it within a master's module is that it can be a verb, it can be a noun. Social prescribing can be an approach, a model, a perspective. It can be so many things. But if we don't sit down and check that we are speaking the same language right from the start in terms of social prescribing, it's very easy for an allied health professional or a community colleague to perhaps have conversations where you end up in misunderstandings, misinterpretations, where there's a level of ambiguity as to what you mean and what your intentions are. We know social prescribing can equal healthy lives. It can work on things like meaningful activity, health creation, exploring all of those barriers that people face, and not just to access the basics, but to actually access healthful lives. And some allied health professional groups, there can be challenges in terms of the perception of role blurring. So particularly thinking of our occupational therapy colleagues, and I say that as somebody who was an occupational therapist, that actually we need to have space for all of us within the ecosystems of social prescribing. So there needs to be space for the right person to work with the individual at the right point in time. And it may not be an allied health professional, it may be a community colleague. And we need to learn to step back. We need to learn to create that space. We need to learn to use that positive language that, we're doing this community referral. We're going to refer you to where we think is best for meeting your needs, for meeting your social needs. And that isn't actually me at this point in time. The expert is actually somebody within the community. And my colleague that presented before, he mentioned about trust. And I just want to come back to that really briefly before you move on, in that AHPs do need to learn to trust community colleagues. We need to stop unhelpful narratives. So narratives where, how can we trust where we're referring people to because we don't know them? Well, let's stop that narrative and let's find something out about the community group. Why don't you actually go and physically visit the community group, understand their safeguarding policies, first aid, go and experience a session, consider it CPD, build those relationships, build that understanding, that and really get to the root of actually what is problem with trust. Why is it? Is it your lack of trust? Is it your is not supporting you to do a community referral? And what needs to change to make those community referrals happen? In our country, in England, in the UK, the Royal Society for Public Health, in 2019, they brought out guidance for allied health professionals. They made it really clear what an AHP's role is in social prescribing, really, really clear. So you need that policy, you need that infrastructure, you need that guidance to really underpin those AHP and community colleague roles to enable them to work together for the benefit of the individual.
Brilliant, Sam. Let me just.
Thanks very much, Gareth. I'm hoping you can still hear me.
Yep, we can indeed. We can indeed. Perfect. Let me just. We need to bridge a gap here towards lifestyle medicine as well and social prescribing, and you've outlined. Let me bring in Melissa. Melissa, from your perspective, how does social prescribing complement precision and lifestyle medicine, in your experience?
Yeah, thank you so much. As I introduced myself, I'm board certified in internal medicine and lifestyle medicine. I'm board certified through the American College of Lifestyle Medicine, and lifestyle medicine is a growing specialty. We probably have about 6,000 to 7,000 physicians now board certified in lifestyle medicine. So we are a small but mighty group. And lifestyle medicine really acknowledges that 80 to 90% of chronic diseases are lifestyle driven. So high blood pressure, high cholesterol, coronary artery disease, mental health, all of these things, obesity, are tied to our lifestyle. So we have 6 official pillars of lifestyle medicine that we use as how we guide our patient care to whole person. So those pillars, in no particular order of importance, are looking at food as medicine, movement as medicine, sleep as medicine, avoidance of risky substances and behaviors, stress management, and social connection. So when we look at connection, I think about that as connection to ourselves, connection to others, and then connection to nature. I'm also known as Dr. Outdoors. That's why I say my DO degree is about. And my current role is a medical director of lifestyle medicine for a very large health system in the state of Michigan where I live, Pywell Health. And we have about 62,000 employees. We have 21 hospitals. And our approach in lifestyle medicine is very different. I was trained in primary care, internal medicine, where we are disease-based, we're a pill for every ill. And as we see, at least in the United States, that system seems to be broken. We have chronic disease running rampant. And so lifestyle medicine takes this whole person approach, really digs deep. When I am seeing a patient, I am spending time, I'm getting into all of those pillars, including social connection. Dr. Vivek Murthy, who is the prior Surgeon General for the United States, he came out with the Surgeon General's advisory in May of 2023, looking at the health implications of social isolation and loneliness, and finding out that it's increased risk of mortality, increased risk of neurodegenerative diseases, and could be the health risk of equivalent of smoking 15 cigarettes per day. So really, I look at asking my patients about their social connection. What does that mean? What does that look like? And I see social prescribing as being a way to activate the pillars of lifestyle medicine, including and really highlighting that social connection. So as an example of what we're doing in my healthcare system with our lifestyle medicine division, and will say that social prescribing, when we've got our colleagues on this call in the UK, in Europe, in Australia, in India, that I feel that we are really just growing this in the United States. I serve as an advisor for Social Prescribing USA. So really looking at ways to bridge this gap and bring this to the health system. So what we're doing within our lifestyle medicine division is we leverage the power of shared medical appointments. And I know that we don't have a national healthcare system here in the States. And so how can we make this accessible and affordable? So these are actually covered visits by most insurances, and it brings in a education piece, and it brings in not only the what and the why of the behaviors that we're trying to implement and optimize, but also the how. So we do cooking for health, where we bring a group of individuals who have a chronic disease, and they learn about why it's healthy what about healthy foods, and then we actually teach them how to cook together. But we know the really wonderful thing is that social support of learning from each other, of supporting each other. And we have shared medical appointments to get people more active, to bring people outdoors, to connect with nature. And so this is just one of the ways that within lifestyle medicine that we are really looking to shift our healthcare system from a sick care system to a well care system, and to really take the whole person approach. I'm really excited to see this area grow. I'm very involved in the American College of Lifestyle Medicine with some leadership roles, and founding chair of the Nature's Medicine Committee for the American College of Lifestyle Medicine, also involved in the Global Wellness Institute, leading their lifestyle medicine initiative. So I think the more that we can have these conversations together, learn from each other, shift the paradigm of our healthcare system, our approach to health and well-being, and really get to root cause, start way upstream, and look at these social determinants of health, looking at these pillars of lifestyle medicine, and really focusing on the role of connection. So I think that's what I have to say. If you want to learn more about what we're doing in lifestyle medicine, you can learn about that, and happy to learn from all of you, and look forward to future collaborations.
Brilliant, Melissa. And I think it's great. How do we bring this all together now? And let me bring in Jill, who's working on a number of projects to do just that at a local level. Jill, could you perhaps share some examples of patient transformation, which you're sort of overseeing at a very large scale across, I think, 6 cities. Can you share that with the audience and with our panelists?
Sure. It's a pleasure to be here. And I've so enjoyed hearing from all the panelists, not just in our session, but in the previous. So it's super interesting. So I'm Jill Litt. I'm a senior researcher at IS Global, and so based in Barcelona since 2016, but I also am a professor at the University of Colorado Boulder. But during my time in Europe, I have been leading, or some of the time leading, a Horizon 2020 funded project, which is an international consortium dedicated to addressing loneliness through nature-based social prescribing. And specifically, we developed a program called Friends in Nature, which is a 10-week group-based, nature-based program focused on loneliness and quality of life. Right now, we're in our 4th year, so we have successfully recruited 1,200 participants in the 6 cities. And these are 6 urban areas: Barcelona, Cuenca, Helsinki, Marseille, Melbourne, and Prague. And what we're showing is that a group-supported nature-based social prescribing program that connects people with facilitators working with providers who initiate the prescription, a screening algorithm to identify folks, refer them to our program. And then together they get involved in different kinds of activities like gardening and bird watching, nature walks, nature-inspired art activities. The idea is to promote belonging, reduce loneliness, and foster social connection. And some of the examples, people talk a lot about the feeling of belonging in the Friends of Nature groups. They describe the importance of feeling seen and heard. They describe new friendships and social networks, and they felt confident in their social interactions. They describe nature as a very important reminder that they are just part of something bigger. They describe feeling safe and free of judgment. That was a very important theme. They also they talked a lot about reminiscence, recalling positive memories. So nature was a way to ignite this experience, fostering these positive memories with families and friends. And in particularly, they talked a lot about, for example, memories with their grandparents when they were young children. They recalled times of unconditional love, acceptance again, and belonging and purpose. And they talked also about, and I thought this was pretty interesting and something maybe that we could delve into more later, is a lost connection with nature. It was almost like an existential loneliness. They were worried about the future. We often think about this with young people, but we did hear from our older populations in the study. They were worried about the quality of the natural environment and grieving the loss of spending time outdoors. It was pretty amazing that we learned in our program, because we worked in assisted living facilities, we worked with families who were older but still living at home with a caregiver. And then we had sort of general population and other high risk and vulnerable populations. But among the older folks that we worked with, we had learned that they had not been outside in over 6 months. And this was just one example coming out of Helsinki. They felt in general very lost at for different reasons when joining our groups. And at the end, we often heard that they sort of felt like they were finally found. So our data is emerging right now. Our trials are almost done. So it's 3 randomized controlled trials and 3 cohort studies. And that we're showing that this holistic approach, so this sort of is like a 5th model of social prescribing, which is group-based and facilitator-led, that it could be easily adapted to different contexts, that it reached people across the lifespan, and reached people experiencing different life challenges. The other thing I wanted to mention that we've really noticed in the implementation of this program is that it's been very beneficial for those prescribing and those facilitating the programs. So our model is one example, resulted in a sense of purpose for care professionals. It inspired hope and motivations to keep going, to do things differently, to have that support from the top, that they could invest their energy into this type of group, and that there was lots of shared learning. So this was really a partnership between patients and the care professionals. One clinician, I'll just close with this, shared with me that it simply changed his life. He saw the progress with his patient restored, and that really restored his commitment to his craft and helped reduce a really significant feeling of overwhelm and burnout. So these are just some highlights from our studies. Again, results will be forthcoming. We'll be having more events in the fall where we'll start to roll out the findings from the 6 cities. Thanks for the opportunity to share here.
Brilliant, Jill. Thanks very much for that. And look, so we've got about 15 minutes left, and we've got 2 questions each that I want to wrap through. So if we all kind of stick to 1 or 2 minutes per answer here, we should be able to get everything on track. So let me go back to Dr. Silva in London. Just what does the future of social prescribing look like?
I think it's really exciting. So there's absolute political willingness in the UK and around the world. So if you look at all governments around the world are recognizing they're spending a lot of money on reactive healthcare, and the public and private spending in healthcare just keeps going up and up. So we do need to move from a sickness to prevention model, and social prescribing is absolutely as core of that. So about 6 years ago in England, so in England we've got 6,500 GP practices or primary care centres, and government came up with something called primary care networks, which enabled practices to collaborate together serving about 30 to 100,000 patients, and there was flexibility. And as part of that, there was additional funding to recruit roles. Now, one of the crucial things is not just recruiting clinicians, but also being able to recruit social prescribing link workers and transformation leads and so on. So this is actually, the additional investment has really helped embed social prescribing as part of clinical work, as part of primary care health centers. In our local hospital, Barts Health, which is the largest trust in England, and they have social prescribing link workers in the wards, and they identify patients ready for discharge, make sure their home is ready for them to go back to. Because as you know, Marmot said, what good does it do to treat patients and then send them back to the condition that made them sick in the first place? So it's a recognition that we should be doing this from where they end up being sick, and to prevent them from being to prevent the sickness as well. And there's a lot of shift from hospital to community, and sickness prevention, which social prescribing would be an absolutely pivotal in achieving those.
Completely agree, and we've got housing in that, but we can go into that at a further date. But Patricia, from your perspective, what does the future of social prescribing look like?
I think it's very promising. When we recognize the value of link workers, social workers being part of that, we have over 3 million social workers globally. We represent the International Federation of Social Work alone, represents over 140 national associations worldwide. We've got projected growth over 12% in the United States alone by 2030. So we're going to have increased workforce. We have a recognition for the need of this. And we're already doing it. Social workers are already doing social prescribing. I explain this to many people through seminars and sessions. We're already doing it. We're just not terming it or coining it or phrasing it as social prescription, but it's already happening. And it's showing very positive results. We see for every dollar invested in social work, we're having a $7 to $10 return on investment. And that means we're achieving greater health outcomes. Another thing I want to mention with the other panel, and was also mentioned earlier, that we have now the digital tools to make this happen. Years ago, we weren't really looking at social determinants of health, and we were prohibited and hindered by the lack of technology. We have the technology now. Health interoperability through FHIR. We are working to bring in functioning. So we're moving away from diagnosis, which I think has hindered our healthcare system. That particular very medically based approach to a social or a biopsychosocial model, which is understanding about functioning and understanding the role of the environment, which is social determinants of health, and how it impacts health and mental health and behavioral health. And that is where social prescription meets us at that particular point. So I think it's really promising. We're going to see, I think, a lot of progress made in the future around social prescription.
Excellent. So we've got 10 minutes left. Professor Satpathy, over to you. What is the future of social prescribing?
So I think, the future of social prescribing, if you look at a global scale, is quite promising. But when it comes to LMICs, there is a lot of potential, and it's just untapped potential. So it all depends on our action. I think collective action, as both governments, policymakers, community members, the academics, and everyone else literally need to engage. And that will determine whether it will be an opportunity lost or whether it will be an opportunity that we will be capitalizing on. And that's something that we need to decide. And that will not be possible, as you rightly said, Gareth, that we need to invest heavily and significantly on capacity building and education. And we need to train our healthcare providers in SDOs, such as social determinants of health, motivational interviewing, community engagement. We need to incorporate the social prescribing into medical, nursing, and public health curricula as well. And that will not be possible unless people are actually aware, because health literacy and even literacy regarding social prescribing badly lacks among medical professionals themselves. They don't realize the value of it. And also we need to also include the social prescribing as an integral part of the universal health coverage plans. I think that will be extremely useful. We need to develop the guidelines, toolkits, and standard operating procedures for local health workers. And we also need to strengthen the health community partnerships. We need to focus on formal linkages between health facilities and CBOs, NGOs, self-help groups, social workers, etc. We need to appoint link workers or community connectors, trained intermediaries who bridge the gap between the healthcare and social prescribing groups. India has already heralded in fact, it has championed the cause of social prescribing, if you look at it historically, because the ASA workers and the community health workers scheme, which has been operational for the past 30 years in India, is actually a testimony of the strength of community-based healthcare services provisioning. But what has happened is, over the years, since it started early 2000, but after that, government has almost forgotten them. They have not increased their wage, their salary. They are still working at the pay scale of 6,000 rupees per month. Can you believe a person going and working for the entire month and just getting paid for 6,000 rupees? Would they feel motivated to work with patients or community members? And then community health workers. The new cadre of community health workers, they're also getting paid very little money. I think if we have to make community and social prescribing a reality, we need to actually invest heavily into it, and the governments and policymakers need to be made sensitized about it. I think there is a huge role that we academics, civil society actors and leaders need to play in this, to sensitize them, to engage with them sufficiently, and probably there is then probably possibility that we might reap the benefits in the next 1 decade. So that's all from my side. I think LMICs, when we talk in the context of LMICs, there's a huge potential, but it will not come into the form of reality until unless we sufficiently engage with it and we sensitize all the stakeholders regarding this particular, regarding the need of it. Because until unless we move away from the traditional biomedical regimen and the systems, we are not going to make much changes. So that's all from my side. I think I have enjoyed listening to others' perspective. I would love to.
Agreed. Totally agree. And let me bring in Sam for quick thoughts.
Yeah, super quick thought. So there's something for me around much clearer guidelines on how we teach our clinical colleagues. So those that are already in clinical practice, already qualified, and those that are coming through as pre-registration or unqualified clinicians, unqualified allied health professionals, because you want to teach in a way that gives the biggest impact and makes the biggest change. When you're teaching, you're creating the future workforce, and that comes with immense responsibility. And to change a clinician's narrative in their brain so that it's not just, let's refer everybody into hospital, that's the best place for them. It's not the best place for everybody. We need to be really, really clear when community is the best place for them. And Lord Crisp wrote a fantastic book on this. Health is at home, hospital is for repairs. So there is something for me around changing education of clinicians and really getting clinicians to understand the power of those community organisations. That's the future for me. Thank you.
Yep, totally agree with you, Sam. And also, when you talk about the look at the German name for a hospital, it's a Krankenhaus, it's the sick house. So that's exactly what it is. Let's bring Melissa back in. Melissa, just quickly, the future of social prescribing.
Yeah, so I think it's very, very bright, and I'm so excited to see it coming into the United States and growing in the United States. And it's, I think, both from clinician driving this, but also the consumer, our patients, our communities of feeling the pains of social isolation and being sick, and that the healthcare system maybe hasn't failed them, but is not really optimizing their whole person approach. So I've seen the growth in lifestyle medicine, a lot of clinicians coming to lifestyle medicine because they're burnt out. They are feel like giving pills and procedures is not really addressing the underlying root cause. And so people come to lifestyle medicine, they learn about the pillars, social connection being one of those. I've been working with Social Prescribing USA, Julia Hotz, who wrote the book, The Connection Cure. So people are finding out about this. And I think this is an amazing way to activate the pillar of lifestyle medicine and really shift the paradigm of how we're approaching patient care. And I know as a clinician for almost 30 years, there is nothing better than to partner with a patient to really personalize this for them and to have them get better. It's wonderful for the patient, but it just warms my heart that I feel like I am actually truly helping someone. So I'm very excited to continue these conversations and to help grow social prescribing in the US and globally.
Fantastic. And Jill, just from your perspective, what does the future of social prescribing look like to you?
Yeah, so I mean, what we've experienced in the 6 cities outside of the UK, but in Europe and then also in Australia and South America, is there's quite a bit of work to do. So I see it as a really important pathway to achieving the prevention and health promotion goals. But policy is crucial, and we heard that on the previous panel. We need the structures and support. We've heard from providers saying that there is simply no way they could ever have the permission to adopt or implement some kind of program like this without the leadership giving them that support and endorsement, and without a broader structure with colleagues to engage in this kind of different pathway. I think tech is needed. We've also heard from our implementers, like the facilitators and providers, that the tech platform, which we've also developed through with the Reset project, is an end-to-end platform that includes all the different user groups, from providers to facilitators to third sector organizations and the participants. But without that, it's very hard to translate this program and scale. And the other piece, I think, in the future is just continuing to develop this new professional pathway. And again, not reinventing, but leveraging the expertise in the community, both inside and outside the health system, to invigorate the volunteer sector and third sector organizations to be part of this collective solution. And I agree that training is really crucial, getting in early for all these different allied professions, and making this part of the solution in the future.
Fantastic. What a fantastic session we've had. I think it's just been truly inspiring to see, clinical colleagues here. And this is real leadership here. I think that the point you make, Jill and Melissa and everyone, I mean, we need to step up here. The leadership has to come to the fore, and particularly from clinical colleagues. Let's we've got the experience, we have the knowledge, we have the data. The data's there. As Professor Satpathy made the point, we have to engage, but I think we also have to step up. One of the most important aspects of this is the financial side of things. So, like what I've been doing over the last 2 or 3 years is bridging that gap into the financial world, making those bold moves in terms of trying to reach those investors. How do you engage with the banks? How do you engage with the investors? I mean, this is not easy work, but we have to take the role. We have to make the business case, because let's be honest, it's not working. The current model just isn't working. Look at the numbers. Look at the statistics. They keep going up, and up. The UK, millions waiting. If you look elective surgery around the world, look at the number of people who have access to healthcare. There's such a gap. There's about 3 billion plus people on the planet. They don't have even basic access to healthcare. So how can we say we're progressing when these numbers keep going up? It's clearly not working. 97% of the budget goes on a sick care model. Only 3% goes on prevention. I mean, the penny has to drop. We're quite smart people. The pivot has to come, So let's start to mobilize that capital and put this business case towards the investors, because from what we've demonstrated here today, and we'll hear in the final keynote from Dennis around the financial side and policies, how we're leveraging the likes of the G20 and wider nations at UN level. So I'm quite comfortable. I'm quite confident, particularly with the group of people that we have here today, that we all work together. We're all part of the same team. We leverage the network. We leverage our intellectual capital. We leverage the structural capital that we have behind us, because each one of us represents huge agencies. We can all work together to make sure that we deliver social prescribing at a global level. So from me, thank you very much to all my panelists. I hope you've enjoyed this session. It's been another fantastic insight into social prescribing, and also shows the opportunities going forward. You can join me and myself, Professor Dennis Oswald, at the last session in about, I think we're on about half 4. So we're just going to wrap this session up now. And I'm just going to take a bit of a break for a few minutes. So, but just thanks to everyone who is here. All right. So thanks to everyone, and we'll talk very soon.
Thank you.
Okay, thank you.